In this video, we will take a look at subtle pancreatic adenocarcinoma presentations and review a case series taking a look at CT-negative pancreatic adenocarcinomas. We present a case of a 67-year-old female with a past medical history of diabetes and neuropathy who's had an appendectomy and cholecystectomy. She was seen as an inpatient for abdominal pain and slightly abnormal liver enzymes. She had a CT scan that suggested mild pancreatitis, and it was suspicious for some ductal dilation of her biliary tree without an obstructing stone or a mass. The CT scan was then followed up with an MRI and MRCP showing prominence of the intrahepatic ducts and a dilation of her common bile duct up to 11 millimeters without any stones, stricture, or mass. The patient also had mildly elevated liver enzymes with a total bilirubin of 1.9 and ALT elevated to 86, and had evidence of lipase to 780 consistent with pancreatitis. Patient was taken for an ERCP for concern for occult cholelithiasis, given the findings of the dilated duct and elevated liver enzymes. She was found to have dilated ducts on ERCP, but no stones. There was, however, a distal common bile duct stricture, which was very subtle. Here you're seeing pictures of the cholangiogram, and you see a dilated ductal system with dilation of the left and right main and common hepatic duct. Here we're seeing a slight cutoff of the common bile duct. Subsequent cholangiogram shows a distal common bile duct stricture in the distalmost portion of the intrapancreatic common bile duct. This distal stricture is somewhat concerning. Dilations were performed, and here you can see a balloon dilator to attempt to open up that area. This was then followed with cholangioscopy with intraductal brushings and biopsies. The pathology from the biopsies reveal that the patient has adenocarcinoma. This was then further reviewed at our tumor board, and the patient was considered for endoscopic ultrasound to look for occult pancreaticobiliary malignancy. On the cholangioscopy, there was no evidence of changes to the biliary mucosa. Here on the endoscopic ultrasound, we see the common bile duct, which appears to be surrounded by a hypoechoic lesion consistent with a mass. On subsequent evaluation with the endoscopic ultrasound, there is a mass that measures 1.5 by 2.3 centimeters in the head of the pancreas surrounding the common bile duct. We further interrogated the portal vein, confluence, as well as the hepatic artery, celiac artery, and SMA, and could not see evidence of involvement of any of these major vascular structures. We performed an endoscopic ultrasound-guided fine needle biopsy to capture histology. EUS-guided core biopsy of the pancreatic mass confirmed adenocarcinoma. Additional CT scans completed staging, and the patient was found to have T2N0M0 stage 1B pancreatic adenocarcinoma by AJCC guidelines. Patient was then reviewed at multidisciplinary tumor board with subsequent radiologic evaluation. The mass was likely covered by pancreatitis and was not seen well on CT scan or MRI. A key point, a CT scan that's negative or MRI which is negative does not always exclude pancreatic cancer. CT scans and MRIs are obviously highly sensitive for pancreatic masses, but because the organ is in a retroperitoneal location, even high-resolution CT scans and MRI may occasionally miss an occult lesion. Endoscopic ultrasound, in the hands of high-volume experts, offers complementary diagnostic, imaging, and staging with enhanced sensitivity and specificity for pancreatic cancer when combined with traditional cross-sectional imaging. We advocate endoscopic ultrasound as a complement to cross-sectional imaging and emphasize its value in terms of imaging and diagnostics beyond just obtaining tissue. In terms of tissue acquisition, fine needle biopsy is rapidly replacing fine needle aspiration, allowing us to obtain histology for targeted stains rather than just simply offering cytology. An example of this may be seen in a case series which we originally presented at the World Congress of Gastroenterology at the National ACG meeting in 2017. We took a retrospective look over a 2-year period at our Cancer Institute at Parkview Health System. Here we picked out 127 patients who had a CT scan for early-stage pancreatic cancer. By this, we meant a potentially resectable lesion that was 2.5 centimeters or less in size. Obviously, for patients with larger sized lesions, CT and MRI are extremely sensitive, and there may not be an additive diagnostic value in terms of EUS imaging to catch occult lesions. EUS would then just be used for tissue acquisition to better look at vasculature. However, in cases where the pancreatic masses may be very small or occult, we see an additive value in endoscopic ultrasound. And out of the 127 cases, 18 cases had a CT negative pancreatic mass. That's actually a significant percentage of patients who have potentially resectable pancreatic adenocarcinomas that may be caught with endoscopic ultrasound when it's performed in the appropriate setting, such as the case which was early presented. Patients who have an indication to look for an occult mass should be considered for endoscopic ultrasound even with a negative CT or MRI. The value add is the enhanced imaging of endoscopic ultrasound in the right hands may detect potentially resectable lesions. These are, of course, very small lesions, often 2.5 centimeters or less than even 2 centimeters, but these lesions are the ones that are the most amenable to treatment and the ones with potentially the best outcome for pancreatic adenocarcinoma. As we see more of a synergy between interventional endoscopists, medical oncologists, and surgical oncologists and radiation oncologists in the field of pancreatic cancer, it's important that we work with one another and we understand what modalities we have to offer to better treat this disease.